Can you tell them a little bit about, what a pharmacy benefit manager is? Because they're involved in every health insurance plan. The names are probably pretty well known. I'll put a little chart up there in a second for people so that they know who they are. Actually, I'll put it up now, and maybe you can explain what does a pharmacy benefit manager do?
Yeah. So a pharmacy benefit manager, we reference them in the industry. We've got all these acronyms. We just call them a PBM. But pharmacy benefit managers, it's actually a terrible term because the biggest ones that control the market, a lot of, three of them control about 75 to 80% of the market: CVS, Caremark, Express Scripts, and Optum. They don't really manage pharmacy benefits. The first PBM was actually created in 1968, and it was just a plastic card that allowed prescription claims to process paper prescription claims, essentially. And then when PBMs really started taking off was in the 80s. United Healthcare understood the need for data, right? Prescription data is key to, manage care, understanding what type of conditions people have. And it gives you a lot better view of a person if you know what prescriptions they're on. So as an entity that was big into managed care, obviously they wanted that prescription data. And prescription benefit managers really took off in the 90s, and they were started for the right reason, which a lot of entities are, right? Which was, let's control prescription costs. Well, prescription costs at that time were, 2% of a health plan spend? Like, they were nothing. Everything was pretty inexpensive, but there were brand name medications that were, more expensive. There was really nothing limiting what a pharmacist pharmacy could charge. So they came in to basically say, hey, you can't charge whatever you want. Let's make sure you're getting a fair margin. What happened is they evolved into this large publicly traded, entity that touches almost every insured healthcare consumer in the nation. And they sit in between the pharmacy and the health plan, essentially. And what their job is supposed to be is negotiate the prices and make sure that the plan is getting the best deal and the patient is getting their copay or co-insurance or whatever their benefit design administered. What they've done, and what Lou has put up here, is it's gotten so overly complex. And this is one of the more simplified flowcharts of prescriptions. But it's gotten so complex by design so that these pharmacy benefit managers can make margin on every step of the process. So a lot of PBMs they've got over 40 ways to make money on a single prescription. And what that does, obviously, if you're making money on all those different pieces and parts, it drives costs up. So they were brought into the market to do good, and what they've ended up doing is just being, I wouldn't say just being middlemen, but they're sitting in the middle, the larger ones, and they're just making extreme profits that are going to their bottom line and not, the teacher, putting money back in the teacher's pocket, helping them afford their medication, things like that. So hopefully that's kind of the overview that you were looking for. But there are good pharmacy benefit managers that have come to disrupt kind of the status quo. So
sure, no, we're not trying to vilify the pharmacy benefit manager. They do serve an important function, but like most things, in the world, is that when you're spending other people's money and you have built a wall between them and the important information they need, the cost, the quality, the prices, the options that exist, it's very easy to manipulate an uninformed consumer, right? Mm-hmm. And managed care, I'm in the process of writing a book right now, which if I ever finish it, it'll probably be called Managed Care. It's Wall Street's favorite spectator sport, because we treat ourselves, the benefit decision makers, as a spectator, as if we have no say, clue, or control over this. And next year, as is going to be a real important year. 2022, a lot of initiatives in transparency and disclosing of information to plan sponsors and their members. And we have a real opportunity. When I say we, people who are dedicated to trying to help, change the trajectory of the cost and quality of healthcare and health insurance. Insurance serves a real purpose, but those companies also are not spending their own money, and it's very easy to hide, profits that go unreportable because legislation doesn't require things like rebates on pharmacy prices. So you talked about that a little bit, but when I did my first pharmacy benefit analysis for a client, I didn't know what to expect, and my jaw dropped when I saw as much as 5,000% spread prices on generic drugs. Like, you think generic drugs, these are drugs that sometimes are in the single dollars, and pretty inexpensive. In reality, they're inexpensive, but when you have 3,000 of them on a relatively small group, a 150 person company, we have 3,000 scripts that are tier one generic type prescriptions that your insurance company is charging you 75, 80, $100 on a $2 medication. That adds up, right? And people don't know it because your member's paying 5, 10, 15, $20 copay. The employer gets absolutely no detailed claims data on any sort of report, even if you're lucky enough to get a claims versus premium report and maybe a large claims. They kind of hide behind HIPAA and things like that, where they don't disclose the real information. And because they don't have to report rebates on specialty drugs and other high cost prescriptions, and they get away with charging the employer and the plan sponsor, really the plan, the full price. And these rebates are getting, behind closed doors, are being redirected to the payers. So um, so so if you were talking to a company, an employer, what are things that they should be questioning if they're large enough where this data should be available to them? Maybe they're getting the data now, but they just don't even know how to interpret it. What's the first question that they should ask themselves, if there is such a thing, to kind of, they're not going to become experts. We're not suggesting that benefit decision makers are the experts. They need advisors, they need consultants, they need insurance companies, whether it be, even fully insured is right for some groups, but how can they start using their leverage as the consumer? Because if you don't up your game, the people that I trust with my decisions, I'm going to go elsewhere. And that's what the power of transparency could be, is that we're going to say, we see it now. I don't believe in like wasting a lot of energy focused on what happened before, right? That's pointless. And part of my book is going to be like, how did we get here? Right? How significantly health insurance and health care changed as they fought over the leverage of the consumer and building these huge networks, and doctors kind of being forced into that system too. And they're really unhappy as well with the medical side of managed care and fee for service, especially primary care doctors. But if you were an employer and you said, hey, this is what you need to question regarding your pharmacy benefits, is there such a thing like, a starting point?
Yeah, I think, getting some type of relative benchmark information is always important, because if you just look at it as a health plan and say, well, we spent $100,000 this month, is that good or bad or normal? We always tie it back to a per member per month. So
Right.
you can kind of normalize the data, and you might have spikes in certain months, but over 12 months, you should have kind of some normalized data that tells you in a very simple calculation, what did I spend between myself and my employees? What did we spend on prescriptions? And if that number is over $100, that's kind of the benchmark that I look at to say you're probably overpaying. There's probably things you can do that will reduce that. And sometimes there's not, especially in a really small population, but $100 per member per month is kind of what I look at to say, the bright lights are shining, the alarms are going off saying, hey, you're nearing a point that you don't need to be.
Right.
So that's the first question that I would ask is, what are we spending? And even if you're not getting detailed claims data, you should be able to get that type of information to
Sure.
then say, okay, what's your book of business spending? And then, there's tons of reports out there of what are commercial payers spending. And, then obviously I've got my own book of business that I can provide benchmarks on. So relativity is huge in understanding where you're at. So then you can say, are we good? Are we not good? And then that starts the conversation. If we're not good, what do we do about it?
Right. Right. And that's great because it's a very simple starting point, right? It's just a directive to give to a benefit decision maker. One of the things that I'm really conscious of is the fact that, somewhere along the line over the last, 20 plus years of managed care, the financial people at companies, like the C-suite, the CFOs, the CEOs, the COOs, they stepped away from the benefit. Even though it's a top 2 or 3 expense for most large companies, they stepped away because they're number people, they're number driven, and they didn't have anything to work with, right? So it's not worth their time to focus on this. So they handed it off to HR, who were in charge of the people and delivering benefits historically, but now they put it in their hands. And in my opinion, that HR is are the perfect people to have a pulse on what the most valuable asset at all companies is: the people. How is our health plan working for them, right? Is it helping us attract and retain the right people? Is it competitive within our industry, benchmarking and things like that? But I think that we need this. The C-suite needs to know the data is going to be out there. You'll be able to see it. You need to get back involved because your HR directors need help. And what contributes, in my opinion, a lot of the time to this constant pay more, get less, is that the C-suite simplified it down to, well, I've budgeted 5%, right? Everybody knows this. Brokers know it. The insurance carriers know that, everything. So you get a starting point of a renewal of 20 plus or 18, whatever it is. And, you negotiate it, maybe go out to market, or if you get a no market offer from your insurance company and you get down to that number, and maybe you can get to that number, and then it's an as-is renewal. But oftentimes you get close to that number, and yet the only way to get to that number, which is the directive from the C-suite, is I have to pass more cost on to my employees. I'm either going to increase the contributions or I'm going to water down the benefits. And over the years, the $5 copay became 10, and then it became 15, and then 20, and 25, and then it got up to 50. And then at some point, if New York is my territory, so I'm familiar with that, there were actually HMO plans had a limit. You couldn't have a copay of more than $50 on an HMO plan. So the insurance carriers started changing their paperwork behind the scenes. They would take their HMO products, which a lot of times had gatekeepers, but sometimes didn't, and they put it back onto indemnity style paperwork, or PPO or EPO type paperwork, so that they could now start implementing deductibles, co-insurance. And that was a strange year as a benefit advisor, going back out to companies that had 10 years of copays and now reintroducing deductibles, and how quickly the consumer behavior and their memory changed. They hated it when the indemnity plans were gone, because they were insulted when you said, here, you got to go to a doctor in this book. I had many a book thrown at me when I was a young advisor in New York City, lugging the books through New York City and sweating. And one of the nice things about technology is all those directories are online now, so I don't have to carry them with me. But the HR people, they need help, right? So they need directives. So coming down to a monetary number and saying to your broker, your insurance carrier, why is my cost this? Like, I want more data. I need more information. And if you take the focus off of the big carrot of the premium, and you say, hey, my premium is completely dependent upon my healthcare costs. So if I can bring my healthcare costs, both medical and prescription costs, down, everything else that bundles on top of that. So you start with your medical and your RX expected costs. So for those people that are out there, the way a health plan premium or fully insured, total exposure is created is you have your expected claims. Then they add 20 to 25% cushion because the stop loss carrier or your fully insured carrier is taking all the risks. They're going to add a cushion to it. And then you add the pooling charges and you add the retention and you add the administration and the broker's fees and all of those things. And that's your total exposure. That's your total, fully insured premium. If you bring the expected claims down, your total costs go down, whether you're fully insured or self-insured. So we have to take the focus and say, hey, what should we know about our costs based on how large we are, right? So if you're large enough where you should be getting the claims data, and if you're self-insured now, you need those reports. A lot of times the insurance carriers believe that those reports belong to them, not the consumer. You're with the wrong insurance company. You need them. They're not going to share them with you. They are hiding something. And I think we all know that. If your broker, if you change the conversation from the premium over to claims, and your broker has no idea what you're talking about, or your advisor, then you're with the wrong advisor. It's an advisor who hasn't evolved, hasn't upped their game, hasn't kept up with technology and transparency, and that's something that you really need to be conscious of. So we talked about rebates, we talked about spread pricing, and by the way, maybe you can help me with an example. I have an example. But I'd love to hear maybe yours because you probably have more insights. Like when we talk about rebates on specialty drugs, like what's the most astronomical example that maybe you could, give to us just to give people out there an idea of what we're talking about?
Well, I think probably the biggest one that's out there and has been out there. So amazing developments have happened in the form of treatments, right? And they come in the form of prescriptions. Typically, there's a lot of research and development. And hepatitis C was one of those categories that really was the benefit of that a few years ago. Hepatitis C treatment was, if you had hepatitis C, you could cure it. And that was something that was not possible before. The problem for plans and even patients, whether they had to pay for it at that time or it hit their benefit plan so hard that they paid for it over a long period of time, it was $80,000. But for someone who's had Hep C, getting it cured, that's a pretty big deal, right? You want to help your people. That's what insurance is for. And when it first came out, it was, how the question was asked, how did you price this hepatitis C medication? And it was $1,000 a pill. And the manufacturer said, it's a good round number. So that's part of the problem, right? Is we have, there's not enough control over the starting price because of this rebate game, because they know if they start at 1,000, the PBM is going to come in and say, well, you have to give us a rebate if you want this product covered. And that rebate ended up being, most rebates end up, 30, 40, sometimes 50% of the cost of the medication. So, if the PBM's keeping that rebate, they're trying to let Hep C medications go through all day long because they're making 30, 40 grand, a whack. Yeah. And so that's part of the misalignment in the industry is like, hey, if that's going back to the plan, great. Now that treatment only costs $50,000 or $40,000, which is a big deal, especially if you're 100 life self-insured group. But that's where the rebates, probably the craziest number in a rebate that I've seen is about half of 80 to 90,000.
Wow. We had an example. You triggered something in my brain. So, one of our great clients who we're lucky to work with, started working with an independent pharmacy benefit manager. And then we actually have another specialty provider that's kind of behind the scenes, right? That doesn't do, it's not a PBM. They don't do all scripts, but they specialize in certain specialty drugs, injectable medications. So You know, just giving people out there, you know, an example of a possibility. So I got an email one day from that third party and said, hey, we're managing the case management notes, which is real important, right? Case management, knowing that these things are going to happen before they happen. So they said, you know, we have a member. They gave me an ID number. They didn't know who the person was that was just approved for a medication. This individual has multiple sclerosis. Could you please help us identify the member and let the plan sponsor, so my contact, the HR director, know to reach out to this person. Just let them know they're going to be getting a call from XYZ company, right? Because this is a new world. A lot of times this never happened before, right? You just, like you said, you'd fill it, the PBM, the insurance company would happily just you know, fill the script, collect the rebate behind the scene. The plan sponsor has no idea any of this is happening. But in this case, we get this call, identify the member. I'm told that, you know, a little bit about this person because I like to kind of know what's happening. And so the end result was this person was going to start a new injectable medication. It has about 27 letters in the name. I can't remember what it was, but it's $115,000 per injection twice a year. It's going to be covered under the medical plan, not the pharmacy benefit. So this person is fully going to be responsible for their deductible and their coinsurance up to their out-of-pocket. So under the old way, this person would have found out that it cost them $7,500 out of their pocket. The employer would have paid over 200. I forget what it was. 115,000 was going to be the charge projected. The insurance company was going to most likely cover 80,000, or you know, that was going to be their rate. So $160,000, $7,500 to the member. My worst nightmare is that it changes this person's life. I mean, it just, the quality of life for this individual goes through the roof. It's a young man, single father of two, from what I understand. And he gets the bill. He gets his EOB 3 or 4 weeks later and finds out he owes $7,500 and never has it again. That's my worst nightmare. Mm-hmm. So the alternative is, and I wish I could have been on this call, he gets a phone call from a company saying, here's an option for you. You can do it that way. It's covered. It's been approved. However, we can provide it a different way. In your home, either a nurse or a physician's assistant, because it's going to come to your home, give you that injection. So now we have some clinical information too, right, that we can go back to the plan with. There's no cost to you. You have no out-of-pocket costs any longer. The savings to the plan was $100,000. So instead of $80,000 per injection, the cost is now $30,000 per injection. So 160 goes down to about 60, and I'm rounding off a little bit, but that's the power of what's out there. So for them, that's not a rebate. That's just us being able to source that medication, you know, differently. Mm-hmm. So I want to just share another screen. So this was an analysis that we did for one of our clients that was was already self-insured. Their cost was, it ran pretty well. This was about a 120 person company. Their pharmacy cost was about $300,000 a year. We had no data. All we knew is the monthly prescription cost. So we gave it to an independent PBM. You might have been involved, actually, potentially, on this analysis. And this was claims from a full years of claims from September through the end of August the following year. There were 2,800 claims. The potential savings was $186,000, maximum projected savings. That's if every trigger and every script goes through the system perfectly, and we take advantage of every opportunity to provide, for international delivery, therapeutic alternatives, rebates, specialty copay assistance, things like that a lot of people don't even know exist those days. So this was, I think, a 55% savings. Now these rebates, they're relatively low. They were currently being retained by their PBM. Client didn't even know that there were rebates, right? No. This goes back to the plan sponsor, in kind of the new world of what's possible. So I don't know if you have any comments about this slide at all, but.
No, I think that's a big. I mean, man, in DC, prescriptions in DC are a huge topic right now, right? And
Right.
nobody knows exactly how to tackle it. And I think a lot of people are waiting for like what type of legislation is going to come out that's going to fix this. And there's private sector solutions all over the place. You just need to know who to ask. And it's incumbent upon brokers and advisors to know what's out there for their clients.
Yeah.
And there's a ton of good advisors out there that know this stuff, and they can educate their clients and walk them down this path. But I mean, $186,000 in prescription overspend for what's probably a fairly small company.
Yeah.
Like, think
Huge.
about what you can do with that. Like, you don't have to have the conversation about, shoot, we've got to increase our copay again. We've got to increase our max out of pocket. Because all you do there is people who, high deductibles were meant to make people consumers. All they did is avoid care. There's a lot of studies on, well, shoot, I can't afford to go to the doctor, so I'm not going to. Well, then those claims ended up being higher when they did have to go and have a major event. So it's really rewarding when you can deliver something like this, and it's not fake money. It's like, no, you're actually going to spend, you know, 10 grand, 10, 15 grand a month less in prescriptions. What are you going to do with that money? You can help build up your reserves if you're self-insured. You can waive copays again, right? You can reinvest into your people. And that's what's fun. That's what's fun about the work that I think we get to do, is it's like, these things are possible. It's just getting the right partners, understanding what can be done, and then starting somewhere.
Yeah, no, absolutely. That's the most rewarding part of it, is that you're not just saving companies money. You're allowing them to take that money. They're already spending it. One of the people I talked to recently had a great take on it, is that, if you're saving a company $200,000 or $1 million, right? I'm working on a prospect right now where our projected savings with very little change, just kind of eliminating this kind of waste, is $1 million or more. It's a company that's only in their second year of existence. It's only going to get worse. So now's
Mhm.
really the time to tackle it. But they can give back to their employees. They can invest it in technology. Even if you invest it back in your business, you're investing it in your employees, because when that business thrives, those people thrive. And this type of approach to healthcare requires a type of employer or benefit decision maker that says, you know, this is important. We're okay. We didn't realize. I mean, the 5%, 10% increase every year is hard to manage, but we've gotten used to it, right? We're
Mhm.
expecting it every year. That's why we budget 5, 10%, whatever the case might be. Maybe if we have a great year, we'll increase a little bit, so we won't tweak benefits for your employees. But when they start to say, hey, that $200,000 is $2 million of new sales, because we need to sell X amount of widgets to net $200,000. So what we're
Mhm.
really giving companies back in reality is, we're starting the year with X amount of sales. And that's
Mhm.
hard to get. When companies start thinking about that, how much do they have to invest into their business to to increase their profits, right? So we're
Mhm.
talking about cutting a top 2 or 3 expense and doing it in a way where we're enhancing benefits. We're lowering out of pocket costs for your employees. I was on a call yesterday with a TPA, a PBM, a stop loss carrier, a case management company. There were 10 people on a call because one member got 2 scripts in a month, right? And we're just trying to figure out, how did this happen? We don't want this to happen. It didn't go to waste. It's fine. We're just not going to get a script next month. But when you have that level of commitment from all these people, and I put that phone call together in about 13 minutes. Everybody accepted that call. Could you imagine? Well, I don't know if you could, but I definitely can. Trying to get an underwriter, a carrier rep, you know, a sales manager on a call from an insurance company, it would take 3 months. So it's just really, people really need to understand that there's a revolution happening. Future topics of this call, this live event will focus on direct primary care and just a lot of the things that are really meant, to enhance benefits. So we're running at about 42 minutes right now. I wanted to, and you and I talked about this ahead of time, so I'm hopefully not catching you off guard, right? I'd like to be able to, end all of these calls, all of these benefit with friends sessions with kind of three takeaways. If you were talking to a benefit decision maker, I know we talked about the first question that they can ask, but are there three strategies that benefit advisors, and there's bound to be some of those on this call too, or employers should be focused on when it comes to the pharmacy side of their claim spend?
Yeah, I think right now the where all the dollars are at is in specialty. I shouldn't say all of them, but a lot of the dollars is specialty medication spend. So that's where a big focus should be, and that's what you should be asking your. I don't care if you're fully insured or self-insured. Ask your broker, ask your PBM if you know, and ask your TPA or insurance carrier. What are you all doing to help me afford these benefits going forward? Because it's all about specialty. There's more, $5,000-$6,000 a month drugs on the market now than there ever has been, and it's not going anywhere. That's where the money's at for the manufacturers. That's where most of their R&D is in. So specialty is where your focus needs to be, and start there. Start talking about it and asking that question: what all are you doing to help me mitigate specialty prescription spend? And if their answer is, well, there's nothing we can do, or, we've got some prior authorizations in place, there's about 10 other things you can do, but you may not be able to do them within the confines of that program. So that would be number one, is specialty.
Okay. That's awesome. Is there a second strategy, something that you could recommend?
Yeah. The second would be seeing what type of data you can get. I know this is hard for HR folks, CFOs. I've never worked with a company or public entity that's like, yeah, we're just not very busy. We'd really like to learn more about prescriptions. Like, everybody's always super busy doing their jobs and their line of work. You can't expect them to be experts. And even if you send them 50 reports, like, they don't have time to go through that. So getting some meaningful data and challenging your advisor, your other vendor partners, give me some meaningful data that allows me to make really solid decisions on. And that's one of the things we really focus on, is data, and having it be unbiased data, because especially in the pharmacy world, you can manipulate data any way you want to sell another program or push people to this pharmacy over the other. And really the data needs to be clear, concise, and actionable, but also not biased, because that creates an added cost typically.
Yeah, I mean, it's interesting you said that, because we had a client with a well-known carrier-owned TPA. No, I'm not here to bash anybody, but so a couple years ago we started slowly kind of picking at the plan, and we moved the stop loss out. There's different kind of profit centers for the TPAs. We were taking things away slowly but surely, and 2 years ago, when I asked them for their pharmacy utilization report for the past year, it was almost like the person fell off their chair. Like, they've been waiting for that question, and there was panic in the background. Like, oh, he's asking for the report. He's at, what should I do? So it took 8 weeks probably to get that first report. They slowed it down, but we were committed, and we weren't going away. And we got the report, and we did our first pharmacy analysis on this client, and they liked the TPA. They've been there for a long time, this client, so they weren't looking to move. They didn't feel like anything was broken, right? They were with a big name, so bigger must be better. And we did the analysis, and it was very similar to the analysis that we just looked at. And went back to the insurance carrier and said, it looks like the TPA, we're probably going to move it because you're not giving us a lot of flexibility. So they went back to underwriting, and they agreed to deeper discounts, and they came back with two options. One was a with rebate option with a little bit, more rebate, more discounts, on the the branded generic drugs, and rebates on the specialty and the higher cost medications. And the client's like, I don't want to have to deal with rebates, and because the way they kind of financially take care of their plan, so they went with option B, which were deeper discounts. But then, all right, so on a piece of paper, on a document, we have deeper discounts, but no one thought we were going to measure those discounts. So we used a data analytics, a pharmacy analytics expert, might have been you, not sure. And we said, okay, can you tell us if we're actually getting the discounts that they agreed to? And to no one's surprise, we weren't.
Right.
They were a couple, 2-3% shy of the discounts, because people don't realize the price of medications is, it's almost like oil. It changes daily, right? So there's an average wholesale price, and you're supposed to be getting discounts off of that. I know that's one way of pricing and everything. So we did it again this year. Last year, we didn't do anything because of the COVID environment. The client basically said, well, listen, we're not going to change. So, but this year we did it, and we found an additional $100,000. There were more rebates than we knew about. The discounts didn't run, and we'll have that call next week. It's a client that renews at the end of the first quarter of next year. So now that the fourth quarter insanities past us, but you have to keep people honest. And like you mentioned, it's the data. If you're not looking at the data, then there's really no value. There's no way of measuring whether you are doing better with one or the other, whether it be on the pharmacy side or the medical side. So,
Yeah.
I don't know if there's another, if you have anything else that you wanted to share, or any points of, hot points for you that I didn't really kind of drive the conversation towards.
No, I think you're spot on with, it's unfortunate. Most employee benefit plan decision makers and broker advisors don't truly understand that signing a PBM contract that says you're going to get X, Y, and Z doesn't mean you're actually going to get that. And when you talk about the no rebate option and the deeper discounts, if there's 45, 50 ways for them to make money on every prescription, they can dangle whatever they want here and slide a hand and take money over here.
Right.
And at the end of the day, you're overpaying no matter what. So that's why I've found a niche in prescription benefits, because of, unfortunately, there's so many bad actors out there, and it's such a complex situation. So starting with that knowledge, but then backing it up with data that says, no, you didn't hit this and you need to. My strategy typically is, let's find a PBM that is not trying to play that game. Let's get you to a place where they're actually focusing on lowest net costs. So yeah, I mean, like you said, the three strategies for me are really a focus on specialty. So words like copay maximization, exclusionary, start thinking down that path, and asking those questions, carving out your pharmacy benefits, which you talked about, and we've successfully done on a case where you do start getting the rebates. That example you showed was 50 grand in rebates, for a small company. That's one person probably.
Yeah.
And they weren't getting that before. So it's very, it's frustrating, but it's so frustrating that there's things we can do about it and just continuing to get the word out. And then the third one is just managing it, right? Don't set it and forget it. You don't have to, as the HR director or even the broker advisor. There's even if it's not me, right? I can't work with and for everybody, but hire someone that knows what they're doing and understands the complexities of pharmacy, and it will transparently charge you a fee to deliver results. No different than an employee.
Right.
So ongoing monitoring, that's what we do typically in a lot of cases, is don't wait till the end of the year and then say, hey, PBM, you missed.
Yeah.
Look at them every quarter and say, hey, you're missing. What's going on? And that will help continue to hold vendors accountable, right? Trust but verify.
Yeah.
that's what we want to look at doing on the pharmacy
Yeah,
side.
getting back to my point about, the book that I'm writing is that you're not a spectator.
Hmm.
Employers, HR
You
directors,
can't afford to be.
employees, right? Even the members themselves, you are the consumer. You are the consumer. And unless you demand more, set higher expectations, and expect more from those people that you trust to help you make these decisions, then you're not going to get more. You're not going to get better, right? So
Yeah.
you need to sniff out who's working for you. Not suggesting that anybody should go out and fire their insurance broker, but you know if they might be doing this, but they might be terrified to talk to you about it because they just don't think you're interested in it. You need to get interested in it, because if your healthcare spend or your health insurance spend doesn't bother you today, you don't think you're in trouble today, 5 years from now, it could be double.
Oh yeah.
It could easily be double. And if you have a problem then, don't wait till then to address it. You have to address it now. So I really want to thank you so much for being my first guest. I hope it was worth your time, and everybody that's out there, if they're listening. I'll be back again next week, hopefully on Thursday at 3:00 with the next edition and another great guest like Trevor. So, thank you so much, man. I really appreciate it. Everybody have a great day, and have a really excellent holiday season. Enjoy your time with your family, and be safe. Take
Thanks
care.
a lot, Lou. Take care.
Bye-bye.